Hello, good evening again. So I will talk about some other uncommon presentations of typical NMOSD is hard to miss. As you've heard before, long myelitis, optic neuritis, chiasmal lesions, the severity of it all will alert you to the possibility. Area Postrema syndrome is increasingly being thought about when you have someone with intractable nausea, vomiting, hiccups. And I must say 10% of patients with NMOSD often begin with area Postrema syndrome, and another 10% will develop it with the course of the disease. And you can see in this picture here, the location of area Postrema in the lower medulla. And on MRI imaging, you can see these lesions here in the medulla, these two white arrows. Now, I want to talk a little bit about myelitis, and that is not always longitudinally extensive. In fact, almost all the long myelitis evolve from a short myelitis. Now, Nazreen Asghari, our colleague in Denmark, has shown this very well. Now, she had a patient who presented with area Postrema syndrome, nausea, vomiting. And therefore, they thought about the possibility of NMO. I think it's a known patient, I think. And then they started sequentially scanning this patient over the course of the next few days. And you can see here, you can see the small lesion developing here in the lower medulla. And then you can see that the lesion becomes a myelitis. And within 10 days, it becomes a long one. So all long lesions begin as a short lesion. Now, it is also not the case that every lesion in NMO has to be long. And what proportion of NMO myelitis is short at presentation? And the answer is about 14%. 14% of NMO are present as a short myelitis. And subsequent myelitis is about long in the vast majority of patients. Now I want to show you two symptoms that did not make it into the core criteria. So we know the core criteria, as you said before: optic neuritis, myelitis, area Postrema syndrome, diencephalic lesions with somnolence or narcolepsy, brainstem lesions, and cerebral hemispheric lesions. But there are some symptoms which didn't quite make the cut. And one of them is painful tonic spasms. Now, tonic spasm it occurs because of a apoptic transmission in the spinal cord. And it's like a motor version of Lermitz. And here is a patient who came to my clinic, and she had NMO, we knew that, and she was recovering from a relapse, and then she developed this in clinic, so I managed to capture it. You can hear the husband describe his attempts to improve his wife's symptoms over the preceding weeks.
About the bed in which we use. So because of that, we bought a new bed with new mattress. It doesn't help.
You can see the left arm becoming dystonic. The left leg is also stretching out. The right one is actually okay. That's the only mobile one. The right arm
so it's a brand new
and leg are okay.
As soon as the water that she drink make the heat go up.
She's experiencing a tight band-like sensation, burning sensation.
Like magnet, like electricity. If I touch her right now, you just shout.
She's struggling with the pain. The left leg and the left arm were the affected ones. The right was a mobile one, so she was leaning over to the left side with that. And now it's passed. That's what happens in a typical tonic spasm.
Yeah.
Now, rarely, exceptionally rarely, and we have reported this, there was a lady, a Scottish lady, who actually had tonic spasms as the first presentation, and then she had a very small myelitis, and this is the lesion can be hardly seen. You can see that you'll struggle to see this as a small lesion there in the cord. And then she turned out to have AQP4 positive NMOSD and subsequently had optic neuritis and so on. Now, another symptom which didn't quite make the cut is itch. as a prominent onset symptom or as a part of an NMO relapse. Now, 25% of patients report itch as a part of the relapse, and sometimes the first ever symptom. And then we went on to report this. And let me play a couple of video just to make you understand what it is like.
Tell me about this episode of itching that you had.
Prior to being diagnosed with NMO, I went to my doctor with a tight banding on my midriff and a severe itching on my midriff, and she thought I might have shingles. So I think she gave me antibiotics, but I can't really remember.
Did you have a rash of the shingles?
No, I didn't, which made me surprised that she diagnosed it as shingles, but she couldn't think of anything else that would explain it away.
And then what happened? That itching moved up?
It moved then into my forearms and into my hands, and it was quite severe itching, so bad that I actually scratched into my skin.
Okay. And you said you scratched it so severely that
I bled.
you bled. Okay. And, right. So this new episode, when was that?
Start of April.
Okay. So what happened?
About a week before, at the end of March, I started getting real bad itching from the top of my back to the bottom, and then that stopped. And then the week after, I had a relapse where I kept getting numbness, tingling, banding. I couldn't walk, I couldn't write. My good eye, my left eye, started going like really bad, and kept going.
I mean, this is now well recognized, but I'm not asking you to image everybody with an itch, but an itch along with other spinal cord symptoms should be a warning sign. Now, there are many other rare presentations. It can occur at any age. The severity can vary. The tempo can vary. I've seen patients with a progressive myelitis over many months mimicking a tumor factor demyelination. Deafness can occur as part of NMO because of the representation of AQP4 in the cochlea. Creatine kinase levels can be elevated. Skeletal muscle expresses AQP4. Flaccid paralysis has been reported mainly because astrocytes do extend into the nerve roots in the spine, in the chorda equina, and that may explain rare cases of flaccid paralysis. NMO can occur in a paraneoplastic context, particularly breast and thymus. And of course, a variety of autoimmune conditions can coexist with NMO. So what am I saying? Am I asking you to scan everybody with any neurological symptom for NMO or scan the antibodies? Do we test all the brain spots? Do we test all patients with MS for NMOSD? Now, there's a problem with over-testing. Assuming 1% of all MS is AQP4 NMOSD, that is, the ratio is roughly 1:100. If you 100 MS patients, you probably will expect at least one AQP4 NMOSD. So would it make sense to screen all these 100 MS patients to find out this one NMOSD? And assuming you have a highly specific test, 99% specificity, there's only 1 in 100 is falsely positive, and the test is 100% sensitive. Now imagine we went on to test 10,000 unselected patients with MS. You would pick up all the 100 true positives because it's 100% sensitive, and you'd pick up 99 false positive patients because the prevalence of the disease is so low, and then you are in trouble. So to summarize, I would say this: test for NMOSD only when the chance of diagnosing it is high. Most of the unusual presentations have already been identified, so don't worry about that. Test typical presentations. If you have one of the core criteria, the positive predictive value is quite high. And the presentation is not classical for other diseases and has been reported as a rare presentation of NMO, you can test. But do not test typical MS. So is it a real symptom or a lesion? Is it likely to be non-infectious inflammatory? Is it classical for something else? If it is, don't test. If it is not classical, but could be a rare variant of NMOSD, then yes, go ahead and test. So think about NMOSD always, but don't test if low probability. Thank you, and we'll have some